Okay, so we are going to discuss Foreign Medical Graduate Exam July 2024 paper. The first question is, normal flora in the conjunctiva comprises of, don't say staph aureus, it is staph epidermidis, but that does not decrease the value of staph aureus, because of course the normal flora in conjunctiva is epidermidis, but the most common cause of bacterial conjunctivitis is your staph aureus. Not to forget, most common cause of bacterial keratitis is your staph epidermidis bacterial. These are all most commons which you should know. Another most common cause of bacterial keratitis means corneal inflammation, which is in contact lens users, CLU, contact lens users. It is your Pseudomonas. So buy one, get three free. Pseudomonas. Most common cause of keratitis in contact lens users who has a history of swimming in pond or washing the contact lenses with tap water. Then it becomes acanthamoeba. All these are your previous year questions. Done? Okay. So CLU with tap water. Okay. Now sudden painful loss of vision with mid dilated pupil. Let's eliminate the options one by one. So it's first optic neuritis. Optic neuritis, there will be sudden. Yes. There will be painful loss of vision. But what about the pupil? Pupil will be mid dilated because there is involvement of the optic nerve. So there is afferent pathway of the pupillary light reflex which is affected. So there will not be mid dilated pupil, there will be fully dilated pupil, and there will be presence of RAPD, relative afferent pupillary defect. Let me show you the real patient video so that you are able to connect the dots. I am hoping that you are going to tell me which eye has RAPD. So this is a patient with optic neuritis. So check this out. Now can you appreciate? Look out for the left eye. So the pupil is dilated, and on swinging flashlight test you can actually see the dancing pupils. Okay, all right. So this is your left RAPD which is seen in optic neuritis. Done? All right, chalo आगे चलते हैं. Let's move ahead. All right, now what is CSR? CSR is your central serous retinopathy. It is actually the exudative form of retinal detachment. Yes, and there will be sudden, no doubts, painless loss of vision, not sudden painful loss of vision. So this is also eliminated. What about cataract? So in cataract there will be slow, painless loss of vision, and the pupil will be normal. The pupil will be normal. It will not be mid dilated. What about acute congestive glaucoma? Acute congestive glaucoma में क्या होगा? When there is sudden raised intraocular pressure, so there is corneal edema. So that is your sudden pain, full loss of vision. Yes, but what about the pupil? Due to sudden raised intraocular pressure, it is going to compress upon the iris, and you know iris has sphincter pupillae, dilator pupillae, which leads to ischemia. When there is ischemia, so there is sphincter damage which leads to mid dilated pupil. So typically the answer is acute congestive glaucoma. Is it understandable? So this is your answer by exclusion. Yes, by excluding the other options one by one. I always and always tell to my students, always and always try to reach to the final answer by excluding the other options. It becomes very easy, very easy. Trust me, ophthalmology is a cakewalk. Yes, you have to believe me. Okay, now history of intake of ATT with loss of vision is there. ATT is anti-tubercular therapy. Most probable drug is, now boys and girls, out of these 4 drugs, one drug is very dangerous drug for the vision. So today in the hospital, so there was one patient who was having pulmonary cox, and he is on ATT. So I was called to the general ward where I was supposed to look out for the visual status of the patient. So when I looked, I could appreciate that there was loss of vision, there was loss of vision, which was slow and painless loss of vision. And I realized that, okay, I need to do some more tests. Let's call the patient to my OPD from the ward. So the patient came to my OPD where I got visual fields done. And on visual fields, I got central and paracentral scotomas. And on doing further testing, I realized that the patient was also having red green color deficiency. So why I am giving you this real patient scenario? Because this is what happened today only, है ना? Okay, so on seeing the drugs which the patient was having the ATT, and the most important culprit is ethambutol, especially when it is taken for nearly 6 months. So its effect starts coming. So these are all the features that you see in a patient who is on ATT, and it may also lead to optic neuritis. See, isoniazid may also be a culprit, but not that much. So out of these options, you are going to mark ethambutol. Done? Okay, now vitamin A deficiency is seen in. So these are 4 options. So what are these 4 options? What is pinguicula? Pinguicula is derived from the word which means pinguis. Pinguis means fat. So this is a triangular patch, yes, on the nasal side of conjunctiva, and this is actually elastotic degeneration of the conjunctiva, and many doctors, many scientists, many researchers believe that it is a precursor of pterygium. Okay, all right, so this is a small bump on the nasal conjunctiva. Okay, all right, now what is Bitot spots? So Bitot spots are foamy areas which look like some sort of foamy appearance, which is present on the temporal side, and it depicts the area of dryness. Wait, I'm going to show you Bitot spots. What is pterygium? Pterygium is again elastotic degeneration of conjunctiva. And it lies on the nasal side, and slowly and steadily it is going to spread onto the cornea. इसको थोड़ा सा डिटेल में करेंगे. So it is coming over to the cornea. It is a wing shaped patch of conjunctiva on the cornea. But mind you, it has the tendency to go up to only anterior stroma. This is your previous year question. Till what level the pterygium actually goes? Only till the anterior stroma. It won't go beyond that. Done. Now, what is the most common etiology of pterygium? Your previous year question. It is ultraviolet rays. Yes. Okay. What will be the clinical features? Another important MCQ I want to address here, since we are doing a little bit of pterygium. Now pterygium is coming from the nasal side. This is nasal side, this is temporal side. Now the moment it is going to come upon the cornea, it leads to flattening of the axis along its path. Now if the horizontal part of the cornea is flattened, so vertical is naturally more curved, so it is going to induce astigmatism. Now my next question to you boys and girls is, which astigmatism will it be inducing? With the rule astigmatism or against the rule astigmatism? With the rule astigmatism, your previous year question, due to flattening along the axis. Flattening along the axis is there. Done. Okay, now since we are talking of pterygium, can you tell me what is the treatment of pterygium? So I am doing just a little bit of touch and go so that I am able to cover a few important PYQs. Hai na? Now can you tell me what is the treatment of pterygium? Yes, one is you simply excise it. You call it as excision, and the name of the surgery is bare sclera technique, because after excision the sclera is left bare sclera, but it has got very high recurrence rate of 80%. But we come up with another surgery which is again bare sclera, but you apply 0.02% mitomycin C for 2 minutes. It is a double-edged sword. You place it for 2 minutes. The sponges, mitomycin 0.02% dip sponges, you place there in the subconjunctival space for 2 minutes, and then you take it out. So it is going to kill the fibroblasts which are there. So it will prevent the recurrence of the pterygium. So it decreases the recurrence, but it cannot decrease it fully. So we come up with a new surgery which is your perfect surgery. Perfect is pterygium extended resection followed by extended conjunctival transplant. So that means the defect which was created, you cover the defect with the help of conjunctival autograft which you take from the same eye. But the beauty of this surgery is that you are going to get 20,000 rupees instead of 10,000 for bare sclera technique. No, I'm just joking. I just say that the recurrence rate is 0.01%. Yes, so this is your surgery of choice, your another previous year question. Okay, now coming back to our options. Okay, so pinguicula, na. We have done pterygium, na. What is Stocker's line? Stocker's line is the iron deposition on the corneal epithelium just ahead of cap of pterygium. So pterygium has got 4 parts: cap, head, neck and body. So it is iron deposition on corneal epithelium just ahead of pterygium. Like if this is the pterygium, so there will be iron deposition. You call it as Stocker's line. So this cannot be the answer. So answer is clear cut: vitamin A deficiency seen in Bitot spots. That is why, so this is your WHO classification of xerophthalmia, in which they have specifically mentioned X1B, B for Bitot spots. Remember, Bitot spots are placed under X1B category. So I am going to show you 2 beautiful videos. आपको 2 वीडियोस दिखाऊंगा मैं. 1 सेकेंड रुकिए. Let me show it to you. All right, where are my clinical cases? Okay, so I am moving towards conjunctiva. So this is your conjunctiva. I am going to show you Bitot spots. Check out the foamy appearance. They are bilateral, present on the temporal side. ठीक है जी, कहाँ होंगे? Bilateral होंगे, present on the temporal side. Mind you, vitamin A deficiency, X1B. Can you appreciate? Okay, this is the right eye of the patient.
सीधा देखो. Now सज्जे देखो, सज्जे. हाँ, सामने बहुत अच्छे.
Okay.
दूसरी आंख भी दिखाओ.
अब देखो.
सज्जे देखो, सज्जे. हाँ.
All right. Now see. Left eye. Okay, so I hope that you are able to appreciate foamy. Now can you appreciate the foamy appearance? Okay, got it. Done. Now I am going to quickly show you pterygium surgery. Normally I show it in my main videos, but yes, I am going to show you here because I want you to have a rock solid foundation while doing at least PYQs, है ना? So these are your PYQs. So I am going to inject 1% lignocaine. I can even go for 2% lignocaine. Yes. Okay. I am going to inject it subconjunctivally. Lignocaine, lidocaine, xylocaine. They are local anesthetics, है ना? Okay. And if I remove it and leave the sclera as such, I'll call it as bare sclera technique. Yes. But you know it has got very high recurrence rate, so I am going to measure the defect and I am going to take the same conjunctiva from the temporal side and I am going to take a part of conjunctiva and place it over this defect which is created, है ना? So this is going to prevent the recurrence from 80% to just 0.01%. Okay, fast forwarding it a little bit. So I have dissected it. Now I am going to put it onto the bare sclera. Okay, so once I am going to put it, I am going to put a glue to stick the conjunctival graft over to the sclera. अब वो 5 रुपए वाली फेविक्विक मत ले आना. There's a fibrin glue which is a medical grade glue, right? Okay. iron out the excess glue and your job is done. All right. Okay, wonderful. So this is the surgery which is completed. Perfect surgery, perfect. All right, let's move over to the next question quickly. Okay, now history of blunt trauma is there. What do you see in history of blunt trauma? So first and foremost, sunflower cataract. It is seen in Wilson's disease. Typically Christmas tree cataract, it is seen in myotonic dystrophy, while complicated cataract you are going to see in cases like retinitis pigmentosa, high myopia, glaucoma and uveitis. So when it is associated with some other disease of the eye, you call it as complicated cataract. But this rosette cataract is typically seen in blunt trauma. Yes. And I always give one example to my students. If you have ever attended my class or ever attended my video lectures, so I always say, so there was a Valentine's Day, but so the girl and the boy, they were best of friends. So you know, आजकल बहुत ज़्यादा होता है ना, जिसके साथ हम दोस्ती करते हैं, प्यार भी उसी से होता है, something sorts. So the boy went a little ahead and the boy developed feelings for the girl, and on Valentine's Day the boy thought to propose the girl with a rose flower in his hand. So boy went to the girl, bent on his knees and proposed the girl. But you know, I like you, but as a friend. So the girl got so angry, girl slapped boy so hard that the rose that he was carrying got stuck into his eyes. Now you tell me, slapping is which form of trauma? Sir, blunt trauma. Wonderful. Rose getting stuck into the eyes, which form of cataract? Rosette cataract. So the answer is pretty straightforward. It is your rosette cataract. I hope it is clear, and we have eliminated the other three options as well. Okay, done. Now next is difference in refractive power in two eyes. Yes, one is +5 diopter, another is +1 diopter. So there is difference of nearly +4 diopter. What is your diagnosis? One is, you will say refractive errors. Yes, there is refractive error indeed. One, you will say malingering. Why malingering? When you have attained the power of two eyes, one is +5, one is +1, which you have diagnosed. So why there will be malingering? Just eliminate it. Next is anisometropic. So they have just asked what is the diagnosis. So this question I feel is kind of incomplete. They have not mentioned that after the correction whether the patient's vision is normal or abnormal. If the question says that even after giving refractive power +5 and +1, the vision is not normal, vision is less than 6/6, then I will go on for anisometropic amblyopia. Yes, and amblyopia is not very specific. Anisometropia is definitely there, because anisometropia is difference in the refractive power of two eyes. When it is more than +2.5, then you call it as significant anisometropia. So amblyopia, तो you simply remove it, because amblyopia से ज़्यादा specific option is anisometropic amblyopia for this patient. But diagnosis is, so they have not told what is the visual status of the patient. So let's take on the face of the examiner कि they have just said एक आंख में +5 diopter है, दूसरी आंख में +1 diopter है. So what is your diagnosis? Diagnosis is refractory error, number one. But if they say, if they keep, I don't know, because this is a recall, I don't know what was the exact, whether this question is complete or not. Some students told me that they have said even after this refractive power the vision was not 6/6, then I will think of anisometropic amblyopia. I have given you both the concepts, so based on this you can easily mark the answer. Okay, all right, so this is your anisometropia. Anisometropia is your difference in refractive error, or significant is when it is more than or at least equal to 2.5 diopter. Done. Okay, let's move over to the next question. Curtain falling sign is seen in. This is a typical presentation of one disease. But first, let's eliminate options one by one. Acute anterior uveitis. Is there any curtain falling sign? No, there is no such curtain falling sign. Optic atrophy. Optic atrophy is irreversible optic nerve damage. Irreversible optic nerve damage. Eliminated. Macular degeneration is when there is presence of lipofuscin on the macula in the form of drusense, or there is neovascularization of the macula. You call it as wet ARMD, age-related macular degeneration. Curtain falling sign is seen in retinal detachment. So what happens is, if there is detachment of the retina, there is sudden loss of vision in that field which was being interpreted by the detached retina. Yes, so the patient will definitely come to you and will say, डॉक्टर साहब मैं तो एक रूम में बैठा हुआ था and suddenly I felt as if मेरी आंख के सामने पर्दा आ गया. Suddenly I felt as if there was curtain which came in front of my eye because there was sudden loss of vision. Na? Yes, sudden loss of a part of field of vision. Yes, so there is typical retinal detachment. I hope it is clear. Yes, if you have read retinal detachment, you will be able to connect the dots, what I am talking of. Okay, all right. Now next is, which of the following is local anesthetic? Now there is a controversy. Some students told me that it was not local, it was topical anesthetic. If they had asked about topical anesthetic, so proparacaine is the answer. Yes, proparacaine. But if they have asked about local anesthetic, then we can use lignocaine, we can use bupivacaine. But you will say, sir, now there are two options. No, they have given a catch. Bupivacaine normal concentration is 0.75%, not 0.5%. But lignocaine, you can use it 1%, you can use 2%. So that is the answer to be picked. Yes, proparacaine is your topical anesthetic. Topical means in the form of eye drops. Local is, you saw me doing pterygium excision surgery. I was injecting 1% lignocaine. So lignocaine, xylocaine, lidocaine, it's one and the same thing. You are not supposed to get confused, boys and girls. Done? Okay, so you know it. Now next is, which of the following is the corrected refractory error? Dekhiye, again there was some controversy. The image, I am not sure whether this was the image, but I am going to give you all the concepts so that you are able to understand it. So the image is falling in front of the retina when the light rays are coming from infinity and accommodation is at rest. So this is clear cut myopia, and for myopia you use which glasses? Concave glasses. Concave glasses are minus glasses. If the image is falling behind the retina and you use convex glasses, this is your hypermetropia. Okay, this is your convex glass, which are your plus glasses. If there is a refractive error only at one axis, you can appreciate that one part is being projected on the retina, another isn't. This is your astigmatism. So astigmatism, you will give cylindrical glasses. Cylindrical glasses, yes. So based on the image which was asked, I think you can easily get over to the final answer. Okay. All right. Now next question is, cherry red spot is seen in. So cherry red spot is seen in multiple conditions. So let's just write the causes of cherry red spot. CRAO. I am going to write, then I am going to give you mnemonic. Don't worry. Then we have got Tay-Sachs disease, then Niemann-Pick disease, then GM1 gangliosidosis, and Gaucher disease. Remember, GM1 gangliosidosis, most of the times it is pseudo cherry red spot. Okay, all right. Then trauma, you call it as Berlin's edema. Trauma leading to cherry red spot, you call it as Berlin edema. Then we have got Sandoff disease. Now, if you will clearly see the option, so we have got two answers. One is Tay-Sachs, another is Gaucher disease. You eliminate Fabry's, you eliminate Wilson's disease. So out of Tay-Sachs and Gaucher's, which one is to be picked? You will pick Tay-Sachs disease because there are high chances of Tay-Sachs disease, while in Gaucher it is seen in some cases. Yes, so this is how you answer this question. But the mnemonic is cherry tree never grow tall in sand. You know, CRAO, Tay-Sachs, Niemann's, Gaucher, GM1, gangliosidosis, trauma, sand of disease. I hope you are able to connect the dots. Yes. Okay. So this is your answer. Please remember this mnemonic because this is very important. Why? Because it can be asked in the form of a twisted repeat. Okay. Now, sudden loss of vision with no fundal glow. There is no history of trauma. So what can be the answer? This is your acute congestive glaucoma. What happens to the fundal glow? Fundal glow will be present. Why not? Because when you are doing distant direct ophthalmoscopy, the light will strike the retina. There is problem in the optic nerve head now. Yes, there is problem in the optic nerve head if the patient is going into glaucoma, if the optic nerve head is getting damaged, but retina is fine now, so it will give a red reflex. Or in acute congestive glaucoma, there can be corneal edema, but since the corneal edema is there, but still you will be able to appreciate the red reflex which will be coming from the cornea, although it will not be clear, but still you will be able to appreciate, and the pupil will be mid dilated. We have already done. Okay, what will happen to the optic atrophy? There is optic nerve which is damaged, but again the retina is well perfused, so you are able to appreciate the fundal glow. So this cannot be the answer. This cannot be the answer. What about acute anterior uveitis? Acute anterior uveitis is when there is inflammation of the iris and pars plicata of ciliary body. So sometimes in acute anterior uveitis, there is a membrane which is formed in the anterior chamber. Remember, occlusio pupillae, this membrane covers the pupil. When this covers the pupil, it actually interferes with the light reflex from reflecting back from the retina. So it appears kind of white. It appears kind of leucochoric. They have not mentioned about leukocoria. They have just said no fundal glow. While in acute anterior uveitis, there can be leukocoria only in one condition, if there is occlusio pupillae. So this is a very hi-fi thing to happen. First, anterior uveitis should be there. Second, occlusio pupillae should be there. Thirdly, the light reflex will be whitish, not absent, typical absent fundal glow. But if there is vitreous hemorrhage, so that the vitreous has become very hazy, it will prevent the reflection of the red reflex from the retina, and hence the answer. But I know you may not believe me, so don't worry. I'll try to show you a video. I had taken a video. Let me see if I have. That was a video of absent fundal glow. Let me see if I have. I'm not sure, but I will try. Vitreous hemorrhage. I don't know if it is in this system or it was in the other system. I had it, I'm sure. Vitreous hemorrhage. No, I don't. Oh yes, I got it, boys and girls. So can you appreciate? Check out. Can you appreciate the fundal glow from one eye? Now I am going to shift my light from the direct ophthalmoscope to the other eye, in which there is vitreous hemorrhage. Now you will see yourself. What do you see? Check this out. Absent fundal glow. There is nothing which is seen. Can you appreciate? This is a clear-cut case of vitreous. See, in such cases, if you have seen the patient, it will be very easy for you to connect the dots. These things cannot be remembered without seeing the patient, and I am sure you are going to remember this. Okay, now the last question, name of the instrument. What was this? If you have seen my cataract video, so there was speculum which was placed in the eye so that I can perform cataract surgery. If you have seen my LASIK surgery video, there was speculum which was placed to keep the eye open, and you know this is your speculum. But the other options were keratome, crescent and side port. These three are used in cataract surgery. Of course, speculum can also be used in cataract surgery. It is used in all the surgeries in which you require to open the eye. So I have put up specifically the image of these three things. So this is your side port, used for giving side incision. This is your crescent blade for making scleral tunnel in SICS. Scleral tunnel in SICS. This is your crescent. And what is this? This is your diamond shaped tip. This is your keratome for making the main incision. Main incision. You can use it for clear corneal incision in phaco, or you can even use it for SIC, small incision cataract surgery, to enter into the anterior chamber. All right, so boys and girls, this was about the discussion of your July 2024 FMG exam. I will be seeking your feedbacks. Let me know how you like the video with real patient integration, and I'll be coming with more such videos. Thank you very much. Best wishes.